Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center's Maternal Health Initiative, along with the U.S. Agency for International Development's Momentum Country and Global Leadership, for a panel discussion highlighting country-led strategies to improve equity and meet the needs of all women and children. I'm Sarah Barnes, and I'll be your moderator today. I direct the Maternal Health Initiative, or MHI, at the Woodrow Wilson International Center for Scholars in Washington, D.C. I'm joining you today from Bern, Switzerland. For those of you who are unfamiliar, the Wilson Center is a critical source of nonpartisan foreign policy research and analyses, where we work to tackle global issues through independent research, open and honest dialogue, and actionable ideas. At the Maternal Health Initiative, a thematic program at the center, we focus on a multitude of global issues, including maternal and child health, gender equity, and sexual and reproductive health and rights, as well as the importance of health systems and policies to better the lives of women and children. Our co-sponsors today, the Environmental Change and Security Program, work at the intersection of environmental change, health, and population dynamics, and their links to conflict, human insecurity, and foreign policy. Today's event is the first in a series meant to elevate country voices in the global dialogue on maternal, newborn, and child health and family planning. Our expert panel today will address inequities faced in their communities, as well as solutions and life experiences in the countries of Nigeria, Pakistan, and Sierra Leone, and beyond. We will focus primarily on the issues of gender-based violence, increasing adolescents' access to health services, and reaching zero-dose children who have not received even one routine vaccine. Before we begin our discussion, I would like to thank USAID's Momentum Country and Global Leadership for making this event possible. Momentum supports ministries of health, country partnerships, and global initiatives to advance global and country technical leadership and learning to achieve maternal, newborn, and child health, as well as family planning goals. I'd also like to thank all of our speakers for taking the time to be with us today, as well as our audience members and our teams at the Wilson Center. I'm really looking forward to a robust and lively discussion and ask members of our audience to please submit questions to our panel to mhi@wilsoncenter.org. Near the end of our program, we'll pose these questions to our panelists. Again, it's mhi@wilsoncenter.org. We have a packed 90 minutes. So without further ado, I'd like to introduce Shamsa Suleiman to give opening remarks. Shamsa Suleiman currently serves as USAID's Mission Gender and Youth Advisor in Tanzania, where she designs programs for equitable distribution of resources for men and women. She focuses her work on youth ages 15 to 35 and uses a rights-based approach to her work. Shamsa, welcome. The floor is yours.
Thank you so much, Sarah, and I hope you can hear me clearly through this map.
Very clearly.
Thank you for the opportunity to speak here this morning. Good morning for those of you in DC, and good afternoon to some of us on the in the Eastern African coast. I hope you and your families are keeping well in these uncertain times. Thank you to the Wilson Center's Maternal Health Initiative for the opportunity to speak with all of you here today on a topic that I consider very, very important. As a result of the efforts by the government of Tanzania and its partners, we've witnessed an increase in gender parity across many sectors. To name a few, the improvements in school enrollment for both primary and secondary education, income earning opportunities, access to key resources such as land and the registration for self-bank accounts, and to some extent, even in decision-making power. But despite some of these improvements, gender inequality persists, and efforts to fully understand and address gender issues remain insufficient across sectors. I'll give a few examples, starting with education. Educational achievement for girls is not seen as an asset. This hampers retention for girls in school. The country faces myriad taboos on how to use modern contraception. There's a lack of availability as well as constant use of modern contraception, and younger males
Shamsa, you're freezing up a little bit.
So There are potentially harmful social expectations concerning the appropriate age of marriage. For example, economic pressures are forcing parents to arrange their daughters' marriages to minimize dowry, bring in resources, including bride price, or lead girls to marry to start to cohabitate as a means of escaping poverty at home, within homes, where we consider homes safe spaces. These safe spaces are no longer safe. Girls are trying to escape the safe spaces. And then finally, limited educational and economic opportunities are forcing parents and girls to conclude that getting started on an adult life includes marriage and motherhood. So that's seen as preferable to remaining at home, going through education, enrolling education, and graduating. According to UNICEF, Tanzania has the 11th highest absolute number of child brides in the world, and the current number is 779,000. According to the 2017 data from our Ministry of Health here in Tanzania, child marriage rates are as high as 64% in some regions, such as Shinyanga, 76 in Tabora, as well as 55. So some pretty high numbers. But what is USAID Tanzania doing to strengthen the capacity of males, women, and communities and institutions, strengthening institutions that we work with to address inequities and meet some of the needs of underrepresented groups? Well, the first thing we're doing as USAID Tanzania, we have a whole country strategy. Our CDCS intends to increase gender equality and youth inclusion throughout its portfolio. Our strategy looks at accomplishing this by designing, implementing, as well as monitoring our activities with a focus on gender and youth empowerment. Socially, we work very closely with community members to encourage understanding, acceptance, and commitment of positive changes in gender-related values and norms. Our social work also includes information, education campaigns related to gender, and this includes teaching basic concepts of gender norms. We work very, very closely with men and boys, and we believe men and boys must be approached and recruited as partners in the process for social change. We also look at something that is key when we look at equity, and that's asset ownership. We continually encourage communities and households to adopt and protect the rights of women and girls to own and control their assets and property. And this includes access to finance through tailored products that suit the particular needs of women and girls. And then something that is key, and I think is important for all of us here, is institutional change, because we're all going to go. At one point, we're all going to grow old, we're going to graduate, there's going to be another gender and youth specialist here at the mission. So how do we strengthen our institutions for the newcomers? Our CDCS, our country strategy right now, our development objective 3 is looking at strengthening the capacity of states and non-state actors to benefit future generations. So here we aim to build the capacity of partner institutions to develop their own guidelines and standard procedures, staffing practices, and financial resource allocation that promotes gender equality. Within healthcare, which is our largest portfolio at USAID Tanzania, we look at, USAID engages women's groups and communities in the administration and oversight of women's health program. This includes hospital and health facility governance. Our programming educates communities, particularly male partners, regarding the functioning and limitation of the health system for maternal and reproductive care, so they can all engage in its improvement and modify processes to meet the health priorities. Lastly, what is USAID doing? And I also think this is something that is just as key as institution, is looking at data. Routine sex disaggregated and gender sensitive data collection and reporting is really assisting our mission here, measure progress towards achieving our project objectives. So now we're better able to make course correction if an activity is exacerbating gender inequality. We can also expand or replicate models that demonstrate progress in achieving gender equality and women's empowerment. Our mission, as well as myself as a passionate gender and youth advisor, we've been clear on the importance of gender and youth empowerment to lift society. We've also made it clear that gender and youth empowerment ushers in economic prosperity that will catalyze an improved quality and way of life. However, we need the same passion and commitment from our partners and our beneficiaries so we can all achieve our goals. Sustaining our coordinated effort on engaging youth, boys and men and women and emerging young leaders, and focusing on the issues that is impacting them will yield an enduring development results in the long term. So again, we're thinking about future generation. So as a do-out for myself today, as well as all the professional colleagues on the call, is to be able to learn of the same approaches and models that Pakistan, Sierra Leone, and Nigeria, as well as our colleagues in Jedpago and DC, are taking, and looking at ways to replicate these models in advancing equity and meeting the needs of underrepresented groups that are diverse in their needs. So we have to be able to tailor our activities and our approaches to meet those diverse needs. Thank you, Sarah. Thank you for this opportunity, and I wish you all a productive session ahead. Asante-san.
Thank you so much, Shamsa, and thank you for leading us off so strongly today. We look forward to having you join us again towards the end of the program for the audience Q&A. So now I will turn to the panel discussion, and we've got an incredible group of panelists with us today. So I'm going to introduce each one of them and then have them do some opening remarks themselves. So first we have Dr. Dure Samin Akram. Dr. Akram is the founder and honorary chairperson and president of the Health, Education, and Literacy Program, or HELP, and is currently a member of the World Health Organization's Blueprint Working Group on Vaccine Safety. She has been honored with the President's Gold Medal in 2001 and Pride of Performance Award by the President of Pakistan in 2004. Second will be Ms. Marian Pleasant Cargbo. Pleasant is from Sierra Leone and a public health practitioner and child and youth activist with over 7 years experience working in poor resource communities where she specializes in teen pregnancy prevention programs and counseling. She is the youth focal person for FP 2030 in Sierra Leone and received an award as one of the most influential women in Western Area Rural District. And lastly, we have Dr. Christopher Uboko. Dr. Uboko is a dental surgeon and a public health professional from Nigeria. He has worked in the Federal Ministry of Health for over 30 years and currently serves as the head of Gender, Adolescent, School Health, and Elderly Care Division of the Federal Ministry of Health. Before I turn things over to Dr. Akram, I just want to remind our audience that you can submit questions for this group of panelists to mhi@wilsoncenter.org. And you can also follow the conversation on Twitter @Wilson_MHI or @USAID_momentum by using the hashtags #MHDialogue and #balancing the power. And that is what we're here to speak about today, is balancing the power. So I will happily turn things over to Dr. Akram.
Thank you, so.
Oh, you muted yourself.
Can you hear me?
Yes, you're great.
Yes, okay, thank you. Thank you for this opportunity to speak with such an enlightened audience about zero-dose children or immunization of children and our personal experiences in Pakistan. So we are all going through this COVID experience, and many countries are still overwhelmed and devastated by this pandemic and trying to cope with it. But one of the positive aspects that has come out of this pandemic is that the world is joined together to look for opportunities and solutions to come back to normalcy and bring this pandemic to an end. And one of the major breakthroughs has been vaccination. And as vaccination has started, we see a glimmer of hope of normalcy returning to our world. Now, vaccination or immunization has been described as the most cost-effective and life-effective endeavor of the 20th century. And in this case, it is immunization of children for vaccine preventable infections. And this was started in 1977 through the expanded program of immunization with just 3 antigens, diphtheria, tetanus, and pertussis, but has now gone beyond, much beyond that, so that there are 9 to 14 antigens, many of them being used by different countries. And through their use, we have seen that 70% of our children have been saved from vaccine preventable diseases, which amounts to like 2 to 3 million children annually, which is a great opportunity and a great achievement. Now, what are the barriers that some children face where they cannot get this life-saving gift and are or succumb to infections? Now, these are called zero-dose children. And what that means by the definition as given by the Gavi, the Vaccine Alliance, is that they have not received even 1 dose of diphtheria, pertussis, tetanus vaccine, and therefore are deprived of the defense that they can have against vaccine preventable diseases. Now, there are close to 10 million such children still in this world, children under 5. And collectively, or these children are aggregated, or 2/3 of these children are aggregated, you would be surprised to know, in only 6 countries: Indonesia, India, DRC, Ethiopia, Nigeria, and Pakistan, where I work. Now, in Pakistan, we have 8% of the total of zero-dose children globally that live with us. And where do these children live? They live in what has been called mixed communities. A lot of these children, not all, but most of these children live in what is being called mixed communities. What are mixed communities? These are settlements. They may be slum areas in the midst of a large metropolitan cities. Like in Karachi, we have the notorious fame of having the most unimmunized children or under-immunized children in the world. So these may be urban areas, they may be far-flung rural settlements, they may be areas that are hard to reach, or they may be conflict zones, and there's so many of them evolving every day in our world. And so these communities do not only have no vaccines or no access to vaccine, but no access to healthcare. They are usually living under poverty, the poverty line, so they're poor. There's malnutrition, and so they are targets to vaccine preventable infections, and they usually have a very high mortality. Can I have the next slide, please? So what you see here is the disparity of immunization as seen in Pakistan. You can see a province called Balochistan, which has 24% of unimmunized children, because it is a desert area, it is an underprivileged province. And you compare that with Punjab on your left, which has only 1% unimmunized children, because this is a prosperous province. Then there are disparities in the provinces and in cities as well. So there is a lot of disparity in finding these children. Now, with all this came along the COVID pandemic, and that has caused even a greater disaster. Can I have the next slide, please? And you can see here the dip in the already suboptimal immunization coverage in Pakistan in last year in April and May, dipping down from 66% of Penta 3 to only 29% and 42%. Because of the lockdowns. And then it has slowly come up, and now we are doing better than the pre-lockdown, and I'll talk to you in a minute about how. Can I have the next slide, please? So what the problems were that a lot of people could not access the vaccination centers. A lot of vaccinators could not reach the vaccination facilities to vaccinate children. There were vaccine stockouts. There was a lot of other problems, COVID-related problems, because of which vaccination is put on the back burner. So more than 50% decline was seen in the vaccination. But what Pakistan has done has introduced the enhanced outreach program, whereby the vaccinators now have field sites where they vaccinate people in villages, in smaller areas, and slum areas. They've partnered with the polio eradication initiative, so that during the polio campaign, zero-dose children are identified, and these field teams take care of the zero-dose children and register them there and then. So a fast vaccination program, also partnering with the community health workers, the lady health worker program, and that has worked very well. Can I have the next slide, please? So where do CSOs or NGOs come in here? Unfortunately, Pakistan has not used NGOs to their full potential as to how they can add value to the work that the government is doing. But some provinces like Sindh has partnered with CSOs like ours. We are a non-profit organization, and we work not on a campaign basis, but on a package basis, meaning we help those who help themselves, we work with communities, and we work not only on immunization, but on other health, maternal and child health issues, the life cycle approach for immunization, and other health-related factors, as well as sanitation, electricity, solarization for water pumps, and whatever the community needs. And as a result, as you can see, the EPI coverage in the areas that we work, both in, this is actually slum areas of Karachi, but also in the rural areas where we have worked, we have a sustained high level of fully immunized children, and we have had no case of polio for the last 20 years. So I have the next slide. Well, this is, I think, the last slide. I want to end here by saying, by three important points. One is that to reach zero-dose children and to reach missed communities, we have to partner with other partners who are doing similar work, with community health workers, and have a sustained enhanced outreach program for immunization. We need to partner with the polio eradication initiative, especially in Pakistan, that has a beautiful micro-planning infrastructure, and use that. And finally, the government should partner more with NGOs and CSOs, because they are the ones who work at grassroots levels, and they are the ones who are the voice of the voiceless and the face of the faceless. So thank you very much.
Thank you very much, Dr. Akram. That is really interesting. And I'm jotting down a lot of questions that we'll get to once we've gone through all of the speakers, but thank you very much for that. Next, we're going to move to Pleasant Cargbo, and she is going to move the conversation to speak more about adolescent sexual reproductive health and access to health services. The floor is yours, Pleasant. You just need to unmute.
Yeah.
Perfect.
So good afternoon from my end, and I am Marianne Pleasant Cargbo, the Family Planning 2030 Youth Focal Point, and I've been working with adolescents and youth in the area of reproductive health. And Sierra Leone is a country that have gone through war and the deadly Ebola virus, and will continue to have a high rate of teenage pregnancy. And it will interest you to know that we have more than 80% of girls aged 15 to 19 in Sierra Leone that have never used contraceptive, and 30% of them will have given birth by the time they are 19. So I'll be looking at improving adolescent and youth access to and the use of maternal, newborn, and child care, FP, and reproductive health. And I'll first want to start with my personal experience and the ones that I've had working with young adolescents and youth. You know, we live in a very, we are living in a secular state, but our people are so religious that when it comes to topics on contraceptives, you have to be guided and tailored as to how you even present the messages to adolescents and youth in schools, to be precise. So as a result of that, we continue to have adolescents that don't have access to contraceptives. Some of them don't even know where to access this contraceptive. So if you notice, we keep having an increase in teenage pregnancy. There are a lot of barriers which young people in Sierra Leone are facing when it comes to the issue of contraceptive and teenage pregnancy. So I'll be looking at some of those barriers and also profile solutions in the area of improving adolescent and youth access to this maternal, newborn, and child care, especially using the Sierra Leone context. Next slide. So I'll be looking at the major barriers to accessing maternal, newborn, and child health family planning care in Sierra Leone. And first, I'll look at adolescents often do not know how to access health centers for contraception care, because the only way you'll be able to have contraceptive in the first place is when you're able to access some of the centers. But when you go to major towns and villages in Sierra Leone, you have a lot of adolescents that don't even know where to access some of those health centers and also contraceptive. And the availability can be limited and the cost of contraceptive in health facility is high. So you have a lot of adolescents that do not even have things to eat or to provide for themselves, and a contraceptive, like for the pills, cost something like $1. So you see most of these adolescents, since they cannot afford this monies for this contraceptive, what they'll do is to go and have sex without contraceptive, because as far as they are concerned, they don't have the money to go for this contraceptive. And even those that have the money, most of the time, the services are not available and they are limited. So for me personally, I work in both urban and rural communities. So when you go to rural communities, you see some of those clear barriers and you see the teenage pregnancy rate is high in this rural community. And also one of the major barriers to contraceptive use has been the myth around contraceptive use. And these are shaped adolescent and youth attitudes about contraception. You have a lot of people that will tell you that when you take contraceptive, you will have cancer. They will tell you that you'll not be able to give birth to children. So because of all those myths, you see adolescents shying away from the use of contraceptives, which has been a major challenge for us that are advocating for the use of contraceptives and for the reduction of teenage pregnancy in Sierra Leone. And another key challenge is the attitude of providers. Because we live in a communal community, we are in rural communities. When you go to a clinic, it's obvious that the person, the nurse that is in that clinic might know your parents, your mother or relatives. So the moment you enter into that clinic and say, maybe I'm here for Depo-Vera, I'm here for IPIL, the first thing they will ask you, is it that you've started having sex? So as a young person, it's obvious that you obviously know that, okay, my mother will know or my parents will know that I'm sexually active. So for me personally, I'm from a very religious family. So imagine me not even knowing about contraceptives at home, and imagine going to a community that I want injectables and the nurse in that community going to tell my parent that your daughter was there for contraceptive. It's obvious that I will be in a big trouble for that day. So this has been a very major challenge, provider biasness and the poor treatment of adolescents. And it's sad to say that our friendly centers are not friendly in most places. You go to a friendly center, you look at the facilities that are there, it's not encouraging. You see the young people, they will go there maybe one time, look at the facilities that are there, and they will not go there again. So we have a lot of those buildings standing, a lot of those spaces standing, and young people not even accessing the spaces. And also adolescents and youths not engaged in designing, implementing, monitoring, evaluating health services, programs, and policies. we are the ones that know what we want. We are the ones having these contraceptives. We are the ones taking these contraceptives. So imagine if government is designing and implementing, monitoring, evaluating health programs and policies, and we, the young people, are not being consulted. You ask now a lot of young people about issues surrounding family planning. They'll tell you they don't know. We've done a lot of engagements with young people, and some of the information that we give them, they are like, this is strange for us. Even for me, as the youth focal person for family planning 2030, I have a lot of challenges having access, engaging people that you're supposed to engage, being invited. So where some of those policies are being made and implementation. So because of that, you see, we keep having an increase in teenage pregnancy. Next slide. So we cannot just talk about the barriers without looking at the approaches to address some of these barriers. So for me, and with the young people that I've been talking with and working with, I think one of the thing that they want to see in addressing some of this barrier is for us to have a shift from one only youth corners or friendly services to having the whole health system meet the adolescent and youth needs, including those in rural communities. Because most times you walk into a house, you walk into an hospital, they'll just tell you, okay, this is the space. For the moment you've entered into that space, they know that, oh, you are entering there for contraceptives. So it's not about you just having a corner of friendly service, but having a whole health system that is responsive. And also outreach programs should be continuous and not just one-off, because what we've noticed is that whenever we have these outreach programs, we have a lot of young people opting for contraceptives. So the outreach program should be continuous and not one-off. And also there should be need for continuous engagement of young people to increase knowledge of the benefits of contraceptive in reducing teenage pregnancy, because there is no way you can involve in sex and expect not to get pregnant. So I think with continuous engagement, our young people will be able to know that if I'm actively involved in sex, it's obvious that I need to protect myself by using contraceptives. And the family and community needs to be supportive, because if the family and community keeps judging, then it's obvious that we will keep having the high rates of teenage pregnancy, and there should be checks and balance where adolescents and youth can be given the opportunity, especially in accessing the health system. And adolescents and youth should be enlightened on the commitment and costed implementation plans. You see, as I said earlier, some of the young people, they don't even know the FP commitment that governments have signed, and we're still struggling on meeting our FP 2020 commitment, talk less of the FP 2030 commitment that we are supposed to make. So these are some of the barriers that we have been facing as young people, and the approaches that we need in addressing some of those barriers. Thank you.
Thank you, Pleasant. So far, you and Shamsa have both really mentioned these safe or really unsafe safe spaces. And I think this is something we'll definitely come back to later in our conversation. Thank you so much. And now we will move to Dr. Ubofo. The floor is yours. You need to unmute. Perfect.
Okay, so thank you very much for having me. I want to say it's a great privilege for me to speak on this forum. I have been working under the program Gender-Based Violence, and a couple of experiences have shown that in Nigeria, gender-based violence have been identified by programmers over time, even before now. But nobody actually has given it so much priority, because the very traditional and cultural norms under which we operate does not allow for the recognition of things like intimate partner violence. It is believed that if you're married to a woman, for example, she more or less is your property. She's one and the same thing as you. And if you have a reason to probably come down on her physically, then it's allowed. It's part of the relationship. As a matter of fact, there are laws in the northern part of Nigeria that permit some smacking of one's wife once you think that she's going off the track. And this is very much allowed. So the issue of addressing gender-based violence has not really been given a serious thought. It is only just recently, especially with the COVID, the COVID era, where we started noticing that there has been an increase in gender-based violence. And that was when we started observing that indeed there is something like gender-based violence. Even though the Nigerian Constitution has has provided that everyone, should have his fundamental human rights, and that nobody should abuse that fundamental human rights. The issue of gender-based violence infringes on persons' fundamental human rights. And so if you engage in gender-based violence, especially against your partner, you are actually going against the Nigerian Constitution. But I would say that it is only just during this COVID pandemic that organizations started speaking more about gender-based violence. Organizations like the UNFPA, the UN Women, and then the UNDP, they came up with this Spotlight Initiative. The Spotlight Initiative is targeting women and girls who have been abused for one reason or the other. And since then, there's been a well-developed program now where we now have a center where persons can come and incident their, incident cases of gender-based violence. So you can incident your case, and then there will be a phone line and somebody at one end of the phone who speaks to you and tells you which sexual assault center you can go to, depending on where you live. For example, in Abuja, we have a sexual response center where, in one of the hospitals where you can go to and you get treatment. So, if there is need for you to be rehabilitated, or for one reason or the other you cannot go back to your house, then there will be, a home where you can actually be taken care of, and be empowered through some skill acquisition training, and you can actually go and begin to fend for yourself and live a different life if you cannot go back to the house where you are receiving this abuse. So it is only now that speaking more about having access to to justice. There is also now a law which was enacted in 2016 that is quite serious about issues of violence, including gender-based violence. In this act, persons found guilty of causing gender-based violence, for example, rape, could be sentenced to life imprisonment. And so this wasn't there before. Now, with that act, which we call the Violence Against Provision Act, Violence Against People's Provision Act, the people are now beginning to have an idea that indeed gender-based violence is an act against humanity, against something that it shouldn't be tolerated, whether the individual is married to you or not. So with those few words, I can go back now to my presentation. Thank you very much.
Thank you. We will be sharing all of the slides after the event. You can find them on the Wilson Center's event page. So we'll make sure that they're available for all who are interested in looking at the slides again after the event. Thank you all so much for all of your commentary. We just heard from each of you about, hi, can you hear me?
Sorry, I thought I should go through my slides.
Yes, okay, great. Go ahead.
Okay.
We'll put them back up.
Can you share it, please? Okay, so this is just an introduction, and according to the WHO, about 30% of women and girls between the ages of 15 and 49 have actually experienced gender-based violence in Nigeria. And the insurgency and protracted conflict have also made the issue of gender-based violence very prominent in Nigeria. This is talking about the Boko Haram insurgency, which has made it quite obvious that many women and girls are suffering under the influence, under the effect of gender-based violence. We know also that 43% of girls are married out before the age of 18. So what this means is that these women do not have the the opportunity to live a life that they have hoped to live, and most of them just move into their marriages without having so much information on how to take care of their lives. Also, 20% of girls and women aged between the ages of 15 to 49 years have undergone female genital mutilation. This we regard as a form of gender-based violence, and there is a lot of programming now going on in Nigeria for the stoppage of gender-based violence in Nigeria. Some 4 or 5 years ago, there were up to 25% of girls who were suffering from female genital mutilation. Today is just 20%. Under there, we have sexual harassment, physical violence. These are the most common types of gender-based violence that Nigeria has. Next slide, please. Next slide, please. Okay, so having understood that gender-based violence in Nigeria is on the increase, we now have development of national clinical protocol on the management of female genital mutilation in Nigeria. Like I said, the UNFPA, under sponsorship of the UNFPA, so we now undertake programs on female genital mutilation. There is also an adaptation of the WHO clinical manual for the care of women and girls subjected to violence. This is a process we have just completed, and it is aimed at providing us with the clinical steps that healthcare providers can take for the management of women who have suffered gender-based violence. And this is being done into the Nigerian context so that healthcare workers can apply it using the Nigerian context. Also, with assistance from UNFPA, development of an essential package for the management of individuals subjected to gender-based violence. We also have the review of National Training Manual on peer-to-peer education. Now, this one is providing information for all and sundry, not just the healthcare workers, with the issues of gender-based violence, and even adolescent health in general. So it's a training manual where we have reviewed it to include the issues of gender-based violence, and this is available for everybody to look at and know what to do should he become a victim of gender-based violence. We also have a gender-based assessment and service mapping that has been done severally during this COVID-19, and that is providing us with more information on what is happening in the area of gender-based violence. Next slide, please. Okay, so the challenges—
Dr. Ugboko, just 1 minute to quickly wrap up because we need to move on to the discussion part.
So
thank you
very much. So the challenges we have are that there's no national level program or plan of action that we are trying to develop. There's limitation to effectively respond to gender-based violence within the existing constraints of human resources. Also, we have issues with data without which it's difficult for us to program for a response in gender-based violence. So I think I'm going to stop here. Thank you very much.
Thank you. And as I was saying before, we will make sure that presentations are available to all of the audience members and fellow panelists so you can review them in your leisure. So now we're going to move to the panel discussion. And just a final reminder for those of you watching online, if you have a question for any of the panelists, including Shamsa Solomon, who did opening remarks, please send them to mhi@wilsoncenter.org, and we will do our best to get through as many questions as possible. But for now, I have a few questions for the panel, and the way we like to do this is like a discussion. So I'll ask a question either directly to one of the panelists or to the whole group, and you can just unmute and hop in, and we just have like quick responses to the questions, and I will keep us to time. So as all of you were speaking, you were really talking about various health inequities, and our event today is really about balancing the power so that there can be more equity for particularly women and children. And so in order to address and improve equity, it's very important, and several of you mentioned this in your opening comments, that we include the voices of groups with less power and access to maternal and newborn child health services and family planning services. And so I'm wondering if each of you could speak to some of the strategies that can be used to include the experiences of those who have not always been the best served by the world's health systems because of their gender or their age or their socioeconomic status, among other things. If you could just speak a little bit to strategies to include voices, I think our audience would really benefit from that discussion. Who would like to go first? You can just unmute and go ahead. Dr. Akram, please go ahead. Thank you.
Yeah, right. So I had mentioned the fact that governments are not partnering with CSOs or NGOs as much as they should, because these are the organizations that are face to face with the people who are being underserved. And therefore, I think that governments should develop modalities as to how to partner, when to partner, where to partner, etc. And that would be a great benefit and an asset to them. So that's one thing. The second thing is that we are now in a technical or technological era with a lot of mobile phones. And we did a project, for instance, in South Punjab, where we were trying to track malnourished children. And these, as I had mentioned before, malnourished children live in these communities that are underserved. And so we had a device by which we used to send messages by mobile phones to the caregivers, the mothers of the children, to tell them when to go back to get their supplemental food, what foods to give the children at home, and then also messages to the community health workers in that area if the mother did not turn up to get the therapeutic food. So, technological devices can be used to reach difficult to reach areas. I have some other suggestions as well, but I'd like the other panelists to talk as well. Thanks.
All right, great, thank you. Pleasant, did you need to unmute, Pleasant? Perfect, go ahead.
Okay, as an youth working with youth and adolescent, we need to have a strategy and a process wherein we as young people should be given the opportunity to access our services, because the truth is we are the ones using the services. I know most people will say young people are zealous, and most times they don't even know what they want, that they demand for things that are not even realistic. But I'll tell you, we've moved past that. We now have a lot of young people that are well enlightened and that knows what they want, and they've been helping their colleagues that do not know what they want for them to know what they want. So I think with the area of implementation and policies, we should not be seen as young people. We know we're young people, so because of that, we are left out most of the times. And I don't think that should be the case. If we are the ones going for the services, I think we need to be consulted in implementation and policies with regard to family planning and access to contraceptives.
Great, thank you. And Dr. Uboka.
Okay, just to add to what they have said, I think there should be a deliberate mechanism for providing outreach services to these underserved population. Such outreach services should be well established, provided in the budget yearly, and sustained in such a way that these persons living in hard to reach areas be reached. Because it is it's there that some people are living in places where they cannot be accessed. Another very important way is using the radio. The FM, there are a lot of FM radios in Nigeria, and they have a good coverage into areas that health workers cannot easily reach. And sponsored programs are now designed to reach these people, and these people have the opportunity to air their voices on the radio to say what the problems they have and how they think those problems can be solved. Also, smartphones that are now abound can be used to deliver messages. Most persons who are underserved can use these means to have a voice on what they think should be included in the programs, that the government should come up with. Thank you very much.
Thank
Sarah,
you.
can I add a couple of points to this? Both Dr. Kobo and I have voiced the fact that it is a male society out there, right? And so we have to talk to males. So far, we usually go to the mothers and tell them what to do, etc. But I think that we should be talking to the males and trying to change their opinion. So that would be one important aspect to remember. And the second one is that females, dealing with gender violence or other issues, family planning or immunization, should be given information as to where they can access help. So, helplines or telephone numbers, etc., should be told to them or given to them where they can access help. So that's a couple of points I wanted to add.
Can I say something?
Please go ahead, Shamsa.
I was just gonna, maybe I can just piggyback to what Dr. Akram was saying, which is working with men and boys as partners and agents of change. I think something that is key is traditionally, I think within a lot of our gender approaches, we viewed women as victims and men as perpetrators of violence. And so what we would do when we were designing our activities, we designed our activities to meet the needs of women and girls. And when we're doing our implementation, our community, the communities that we're speaking with were predominantly female. That wasn't a bad thing, but that wasn't also the most that wasn't also the smartest thing to do, because we were leaving half of a society out of discussions. And so what we're doing now at USAID Tanzania is really working with men and boys as partners. So we have a gender analysis that we did that was targeting men, constructive male engagement. It's called constructive male engagement. And we hired a male Tanzanian feminist, to go out into communities, identify male gender champions, sit with them and speak. The discussions were divided by ages for the obvious reasons. A 15 to a 21-year-old's thoughts on gender equality may or may not be different from a 50 and above years old. So he went around the country and we collected this data and we put it together. That helps us in our approach to engaging men and boys. So another resource that we also have comes out of our Global Health Bureau in Washington, which is called the Do's and Don'ts of Male Engagement. And so it's a resource that's online, it's public, so for anyone.
You've frozen, Shamsa. Okay, I think your connection is a little bit rocky right at the moment, so I'm going to jump in. Oh, there you go, you're back. Oh, but go ahead. Did you finish? Oh, she, okay. Okay, sorry, great, okay. So that's wonderful. We speak quite often about the engagement of men and boys, and we had an event recently talking about bodily autonomy and the importance of also always making sure when we do engage men and boys that we don't do it in a way that takes away the power and the decision making from the women and girls. And I think the things that you all spoken to really resonate with those same ideals. What your comments have so far have led me to this next kind of question of the importance. It was mentioned, Pleasant mentioned, consulting young people when you're creating interventions and policies. And I wonder how you have on the ground been able to actually consult with young people, parents who are making decisions and needing to access vaccines for their children, women who have experienced violence. What are some strategies to actually access these communities that need to be consulted in order to inform these changes? What have you seen done, or what have you done to actually bring these voices into the conversation? And I think we lost Dr. Owoko, so hopefully he'll be able to come back on. I know his connection was a bit temperamental. So whoever would like to go, please unmute. And we can talk a little bit more about how you actually engage the voices of populations that are usually left out of the conversation. Go ahead, Dr. Akram, I can see you're unmuting.
Since nobody else is talking, I thought that my young friend would talk about youth. But what we usually do is go and give talks in schools. I mean, that is where we come across the youth. But there is a limitation there, because especially in Pakistan, because we cannot openly talk about sex or using birth control, etc., because this is a very an issue that should not be spoken to with young people according to our norms. But we do talk about things like immunization, nutrition, exercise, healthy lifestyles, and all the issues that would create healthy living. And I must tell you that long time ago, I mean, I've had a long run so far. We had what we call a mela, which is like an exhibition where we have lots of people coming in, and we had these jars of worms, and the young children came to see them, and then they ran and called their parents and said, "Look at these." And then they said, "You know how you prevent getting these is by washing your vegetables really nicely." So it is the young teaching their parents, and that can be used, and that can be done through schools. And of course, there are other ways like football clubs or other clubs that can be reached. Thanks.
Thank you. Pleasant, did you want to add to that?
Yeah, so just with the issue of limitation on talks, as Doc have mentioned, I think is the same thing for us here in Sierra Leone. When you go to schools, you are limited as to what you're supposed to say to the pupils. And even with contraceptive, there is no way you can give contraceptives to pupils when they are in their school uniforms. But you notice most of these outreach programs are being done during school hours. So for the set of pupils that will be in school, it's obvious that they will not have access to the contraceptive because there is no way you can give them contraceptive when they are in their school uniform. I remember for World AIDS Day, we were distributing condoms in various parts of the capital city. And standing in one school, you see a lot of adolescent boys, around age 12 to 15 came to us and they were asking us to give them condoms. And I was like, I actually want to give you, but I'm not permitted to. And the boy was like, do you think I'm not having sex? You need, I was like, I remember after that program, I did a Facebook post and I have a discussion with some of the people that I work with at the office. I was like, I think it's high time we look at some of those policies that are saying young people should not be given access to contraceptive when they are in their uniforms, especially if they are sexually active. I think there is a way to do it, because one thing for me, I think outreach is very effective, but outreach are distorted. You see, it's a one-off thing. People just go to communities, issued contraceptive, maybe once or twice in a year. So I feel if we can be doing it, let's say if we now go and give the 3 months methods, before the end of that 3 months, we can go again and issue this contraceptives. So those same people, by then we'll have the first time users, and we have those that have been taking these contraceptives continuing with their methods. But the moment we are done with the outreach, you'll notice that most of them will not even go again to those clinics because of some of the things that I've mentioned, provider biasness. So they'll obviously not go again to the centers for these contraceptives.
Thank you. Thank you, Pleasant. Dr. Uboko, I'm glad you could come back to us. Can you hear me? You just need to unmute. Perfect.
Yes, I can.
I
was off.
That's okay, it happens. I was just asking the other panelists about being consulted. So the groups that you work with, so for you, you're talking about, women and girls who experience violence. And I was just asking them about how do you get the voices of those women into the policymaking space, or into, how do you actually reach out to the women to hear what they need and what's helpful to them? Do you have any strategies that you use?
Yes, so one of the strategies that we think we can adopt is to empower women activists. Women activists, are all over the place now, and if we can empower them through sponsorships, they can do a lot to encourage government to get to hear the voices of women who suffer gender-based violence. Like I said, it is a cultural thing. It's going to take time for people to understand that they are not supposed to be abused the way they are usually abused. And so we need the services of women groups, women activists who will keep speaking to government, going for advocacy in either at the National Assembly or at the sub-national levels, so that government will begin to take the issue of women in the villages, in the communities who suffer daily in the hands of their partners. So it is also in this same way that the women in the communities will begin to get information that it is not their place to be abused, and that they should speak up against it. Also, like somebody has said, men should be involved, because some men do not actually understand some of the things why they go in commit gender-based violence. Some men do not, they just feel something that they're entitled to. But if you begin to educate men and tell them the consequences of gender-based violence through the work of these women activists, yes, most of them are beginning to change. They will begin to change their attitude about inflicting all sorts of pain or something on their partners. So I feel that women activists, the civil society organizations, these are the people that are usually in the forefront, and the religious organizations. These are the simple, practical ways in Nigeria where the voices of women who are suffering under the burden of gender-based violence will begin to be heard. Thank you very much.
Yeah, and Dr. Uboko, since we have you here and you're unmuted, I just wanted to do, before we move to the audience questions, again, if you have a question for the panelists, it's mhi@wilsoncenter.org. We have a few questions coming in, but I thought I might just ask each of the panelists one quick, well, kind of quick question, just get a little bit more from each one of you before we turn it to the audience questions. And so Dr. Uboko, you had started to mention, and I'm curious what are the service components of the one-stop shop gender-based violence response center that you mentioned?
Okay, so the service components are that, first of all, women can now report to a center. The center that have been chosen in Abuja is a social development center where somebody can pick a call. Anyway, the lines, you are not supposed to pay for those lines. And so you can make a call to that center, and you will be referred to a more like a hospital where if you have needs for treatment, you will be treated. There is also a provision for you, if you require it, for you to access the police. It's very easy for them to refer you to the police if it's a case that will require the police. So that service is provided. Also, you could, if you need to be empowered, if you do not need to return to your home, there is now a kind of shelter where you can come in and you'll be treated properly, including giving you some empowerment, some kind of empowerment capacity building. So those things are some of the service components that we have under the present system. where we have adopted here in Abuja, the capital of Nigeria, for taking care of persons who are victims of gender-based violence. So we have justice in it, we have health provision, and then we have social, you know, if you need more social adjustments, yes, there's also a center where that can be given. And of course, we are saying that apart from all this, that we should continue to advocate through the media, through the community, you know, centers, through it, to get to the communities, to tell people, men especially, that the practice should be discontinued, and that there are laws now that that can you know, hold you responsible for committing you know, committing gender-based violence on women. Thank you very much.
Great, thank you. Pleasant, I'd like to move to you. One of the things that I wanted to come back to is ask you, how do you feel that the Ministry of Health incorporates the points of view of youth in its planning and programming? How do you feel that they're actually incorporating the ideas and needs of the youth in their programming?
Okay, so as I mentioned earlier about young people not being consulted when some of those policies that are affecting young people are being made. So for now, we have the technical, the family planning technical working group meetings, wherein most, well, for now, as the youth focal person, I'm most times being invited into that meetings, although you only have the leader for the reproductive health in that meeting, the minister and most of the policy makers are not there. I think what we need to have now is to have at least a youth representative in some of those policy making panels. It's not as if we know it all, but it's somebody mentioned about learning process. I think it's a learning process. The moment we are there, we'll be able to talk about the things that are affecting us. In fact, it will give the government more ideas as to how they can draw up policies that are affecting young people. Because the truth is, we keep having an increase in teenage pregnancy. And most times, young people, especially adolescents, they are afraid or ashamed to talk to older people when it comes to the issue of contraceptives. But when they see you as a young person, they are comfortable talking with you. For me, I have a lot of adolescents that I do talk to with the issue of contraceptives. They are free to call me, to talk to me on this issue. They know I will not judge them. We do not have any barriers talking. So they are so comfortable talking with you. So I think if we have young people in some of those tables, because nothing cannot be done for us without us. It's not about you just planning and coming with those things to us and you just expect us to accept it as it is. So I think the ministry should find a way to have, maybe have a youth desk wherein young people, you cannot have the whole of young people, but you have a lot of young people working on health, working on sexual and reproductive health rights and family planning. We can sit and have some of those policies. We can table the discussions of those young people. I remember having the first family planning youth conference with young people through the support of FP 2020. We had a lot of conversations from young people telling us about how we can be able to tackle some of those issues of teenage pregnancy. So if the government will have this continuous dialogue, not only in the city, but going to rural communities, having this dialogue, I think we can be able to reduce the rate of teenage pregnancy and unmet needs of contraceptive that we are having now as a country.
Thank you. Thanks, Pleasant. Thank you very much. Now, Dr. Akram, both you and Shanta had mentioned data and disaggregated data was also discussed, and I'm wondering if you encounter any gender differences in immunization of children in Pakistan in general, or in those areas that you've mentioned in your presentation where the need might be greater. Are you noticing any gender difference in the children being vaccinated?
Okay, so this is a very interesting question. No, we are not. We do not see any gender difference in children being vaccinated. There are just as many female children being vaccinated as male children. We've looked and analyzed the data quite frequently. The gender difference comes in the caregivers, because it is usually the mothers who would bring the child for vaccination. And because of the restriction on the movement of women, these mothers are unable to bring these children for vaccination. And that is what causes zero-dose children, because usually, in rural areas, they may be busy with farming, or the men might be out of the house working all day long. The vaccination centers are open only in the day till 2 o'clock. And by the time the men return, the vaccination centers are closed. So that is where the discrimination comes in. So therefore, what the government is now doing is, for one, opening up the vaccination centers much longer till the evening, so that men can accompany their wives to bring the child. The second thing that they are doing is that they are going to train the lady health workers, which is a government employed community health workers, as vaccinators, so that there is an outreach and there's house-to-house vaccination when women cannot go to facilities. And thirdly, they are thinking of getting female vaccinators, because male vaccinators do not have access into the homes even when they do outreach. And then of course, the help of NGOs, etc. So this is what the government is doing to overcome this gender discrimination in access to immunization due to the females. Yeah, thanks.
Wow, thank you. We're about to move with a couple of questions coming in from the audience, but I wanted to quickly ask Shamsa, since you so nicely stayed on this panel this long, you mentioned in your opening remarks, I believe you said, like, fleeing safe spaces, that women are fleeing and girls are fleeing safe spaces. And I know Pleasant also spoke about this, and Dr. Uboko, about having safe spaces for women and children. Can you touch on that just a little bit more, of what are the reasonings that people are leaving the safe spaces, and why are these spaces that should be safe no longer safe? I know it's a really big question and we only have a few minutes, but I just wanted to come back to that point you made.
Well, part of the reason they're leaving, Sarah, is because the spaces are not safe. From birth, almost from cradle to grave, girls have been seen as some sort of baggage. If you're sitting in the home, you're not performing domestic duties, you're not living to an expectation of a bride, of a woman who's going to give birth and raise her children well, you're seen as baggage. If there's an economic situation within the home, who do they turn to? They're likely to turn to the female first and say, if you get married, Shamsa, we'll get something. We'll get something in return, whether it's through cash transaction, whether it's through domestic animal exchanges. I mean, the same responsibility is also turned to boys, who are forced to go outside and provide for their families. But for the female, it's ownership of her body. She lacks that, because she then has to trade that to a man. So I think that's an issue within the home. You find that there's very little safe spaces to even speak and voice your opinion. And you find that a lot of these girls then have to walk a couple of distances to school. That's also another space that's not really safe, because there's, border drivers, this little tuk-tuk drivers that are driving around, and they're seeing the girls and they're chatting them up, and then they get to school. And sometimes you find that even within school settings, there's still not a safe space for girls, to complain. We have canings of schools here in the country, and, girls have complained sometimes through caning that the skirts have gone up, and expose their underpants. And that's humiliation. And so you find that even with given all those unsafe spaces, what do girls turn to? Sometimes they turn to men who offer that safe space, actually sit down and listen to them. But in listening to them, they end up having sex with them, and often it's unprotected safe sex, because these girls are just so young to know what is right and what is wrong, and even bargain for safe sex. And use of condom within sex, there isn't that power to bargain and end up falling pregnant. So it's an incredibly unfortunate situation. But we do have activities that are looking to tackle that and to challenge that. And I'm glad to say we actually have partners, both fathers and mothers and members of the community.
Thank you. Thank you for those additional comments and really talking some about this cycle. And that actually brings me to a question from our audience, which anyone can jump in quickly to discuss, but I think it's mostly for Dr. Ogboko because it is about violence. The question is, when one partner is abused by another, children are also impacted by the abuse, which can perpetuate the cycle of violence in the next generation. What do you propose to address this issue? You need to unmute. There you go.
Can I get a question again, please?
Sure. It's about, it says when one partner is abused by another, children are also impacted by the abuse, which can perpetuate the cycle of violence in the next generation. So what do you propose to address this issue? How can we stop this violence in this generation so it doesn't go on to the next?
Okay. So the most important step one should take now would be for our communities, local traditional communities, to be properly educated about the dangers of gender-based violence. Like I said, most of them do this without knowing that it's an offense, that it's not allowed any longer in the modern world, and that it has a lot of psychological effects, medical, psychological effects, and social effects as well on women who are sufferers of gender-based violence. And the issue in Nigeria is even more critical in the sense that we do not have enough centers where women who have such psychological problems could go to. So that's a very big problem. So I think village communities should be properly educated, especially men who I would say are they cause most of the problem, I would say. So men should be brought in to, and a lot of advocacy should be brought into their groups, to the men's groups, and if possible for men's group as well to help in disseminating this information. So that's the first step. The second step is for individuals, awareness to be created amongst individuals for them to understand that so that anywhere you are, you will be able, if you can identify gender-based violence, you will be able to call on the authorities and say that, yes, I suspect that gender-based violence is happening in such a place. So if people know that there is a possibility of them being caught or for them being taken to the law, they will begin to push away from there. It's just like what we are doing in female genital mutilation. Female genital mutilation is such gender-based violence. People are cutting women and children because they feel that this is the way to go, that's their culture, and that they can't move away from their culture. But now that they know there are laws that are going against female genital mutilation, people are now beginning to move away from that practice. So I feel that information to the rural populace, information to all populations, everybody, knowing that these things are no longer acceptable. It will go a long way to stop these things in future generations. Thank you.
Thank you. We just have a few minutes left, and we're about to go to our closing remarks by Dr. Koki Agwa. But I just wanted to ask Dr. Akram very quickly, a question came in asking, what can you tell us about the relative cost of reaching zero-dose children or communities by CSOs like yours as compared to outreach by government health staff? Is that something you could answer rather quickly, or just is there a big cost discrepancy between the two?
So the vaccines that are given are free by the government, and because we also have immunization centers which are working with the government gives us a supply of vaccines free of cost. Now, the government pays the vaccinators and we pay our vaccinators. So the cost actually is not that much different. It is actually the cost of what we have to pay the person who's vaccinating. And so there's not much difference in that. But the vaccines are free. Okay.
Thank you. Thank you very much for that point. Okay, so now we will move to our closing remarks. And unfortunately, Dr. Agrawal was not able to be here today. So we have a video of her remarks, but I'll just give her bio briefly. Dr. Kogi Agrawal is the Project Director of USAID's Momentum Country and Global Leadership Program and Vice President of DC Operations for JPIGO. Dr. Agrawal is an internationally recognized expert in safe motherhood, reproductive health and family planning, policies and programs, and has more than 25 years of service delivery experience in reproductive health, family planning, and maternal health. And now I will just show you her final remarks.
Health inequities often occur in populations that lack social or economic power, including women and girls, minorities, adolescents, and poorer rural communities. Moreover, health inequities have significant social and economic costs that can further widen the gap between the advantaged and the disadvantaged. Many of these disparities can be remedied by addressing the social determinants of health. Today, we have heard several powerful examples of how countries are working towards that important goal. Social norms and economic vulnerabilities perpetuate gender-based violence. Nigeria's Federal Ministry of Health is working to elevate this important area within the health sector by adapting global guidance for gender-based violence and intimate partner violence services and integrating the first-line response into maternal, newborn, and child health and family planning services. In Pakistan, a large population of children have not even received one routine immunization, indicative of entire communities that may not be reached with other health services. These disparities have been exacerbated by the current COVID pandemic. Civil society organizations like the Health Education and Literacy Program in Pakistan, faith leaders, and other community influencers are a crucial link to reducing the underserved community members. These trusted community leaders can help uncover barriers to accessing and accepting vaccination and other primary healthcare services. Our colleague from Sierra Leone shared the unique barriers that adolescents and youth face in accessing quality, respectful maternal, newborn, child health and family planning care, often resulting in higher levels of unmet need for contraception and elevated risk of maternal and newborn mortality. Youth leaders like Pleasant are leading the efforts to build political will for an adolescent responsive health system. The health sector has an important role to improve equity. Health systems can serve as a platform from which to shape social and economic norms. And countries are taking on a range of policies and programming options, including expanding services to all through universal coverage, measuring and monitoring inequities, involving socially disadvantaged or marginalized groups in decision-making, and collaborating across sectors, just to name a few. There's so much to learn from their examples. It is important that as a global community, we learn from each other and the effectiveness of these programs in reducing the differential coverage and outcomes between advantaged and disadvantaged. We look forward to helping countries collect, track, disaggregate, and use routine data to measure the effects of the equity-focused programming on improving coverage and quality of life-saving interventions and identifying the best practices to accelerate progress. This is a critical agenda for reaching the targets of the Sustainable Development Goals. Thank you for joining this discussion today. We hope that you will continue to learn and share what's working in your country to close the equity gap and balance the power to meet the needs of all women and children. Thank you.
Thank you, Koki. Hopefully next time you will be here with us. So thank you so much. And thank you to all of our panelists for being here today and really joining us in this conversation and sharing so many country-led strategies. I've learned a lot, and I'm sure our audience has as well. We're out of time for today's, but in case anyone in the audience missed any of the discussion, there will be an event recording that will be available in the next 24 hours on the Wilson Center's website. We will also produce a summary of today's event, and it will be available on the .mom column on our blog, New Security Beat. So thank you again to our incredible panelists and to USAID's Momentum Country in Global Leadership for making this event possible. And thank you to our audience for tuning in. Have a wonderful rest of your day or your evening. Be well. Thanks again.
Thank you very much for this chance. Goodbye.
It's wonderful.
Thank you. Bye.
Thank you
Thank
very
you.
much.
Bye.
Thank you. Thank you.